So here we come to the combination, the treatment algorithm, the slides that I like. When we take all the medication, how practically it can be applied in a given case. So in chronic heart failure, it depends on the first, of course, the assessment of the reported left ventricular ejection fraction, the 40%. If less, so you go step by step as we discussed, diuretic, S inhibitor, beta blocker, MRA. If no, we'll be just focusing on the hypertension management as we highlighted in the heart failure preserved ejection fraction, S inhibitor and beta blocker. Here, in terms of the clinical improvement, could be the clinical improvement is there, so you just continue, or it is not yet the clinical improvement at the level required. So in this case, you think about the other medication. Other medication means switch to ARNI, or consider ivabradine if the patient may be eligible to receive it, or digoxin. And then again, the clinical improvement is there, so just continue with the listed medication. If not, so you have to consider the maybe diuretics, some devices can be there. In acute heart failure exacerbation, you can refer to the part 1 to discuss or to see in details the acute heart failure management. Here, coming to the most interesting slide, after discussing all this medication that summarize the most important information we have to grasp. Here we can see all the medication with the grade of recommendation and level of evidence, and some comments regarding the clinical benefit of the net clinical outcome in a given case. We can see here almost all the medication and some of the device intervention have grade 1 indication or grade 1 recommendation in patient with heart failure, except for the digoxin in case the patient has no AF and ivabradine. In terms of level of evidence, we can see here for the medication level of evidence we have ACE, ARPs, beta blocker, and MRA, and B for the rest of the medication. You can see here whether the medication has impact on mortality or mortality benefit, and of course you have to understand that improving survival means mortality benefit. So using the term improved survival or mortality benefit is referring to the same. So when we call it improved survival, this mortality benefit. And here for digoxin, for example, in absence of AF, it has no effect on survival, very clear. Here, ivabradine, no effect on survival, nothing mentioned about this one. It reduces hospitalization and if add on the ONT as we highlighted earlier. So paying more attention to this table with this one as a summary of the impact of the medication and its place in the therapeutic plan of chronic heart failure is quite important to notice. At the very end, before we end with our part 2, the other medication, statin, anticoagulant, CCP, and some other medication. Just to highlight, the statin is not recommended on HF diagnosis only. Means if heart failure with no other condition, heart failure per se is indication of statin, it is not that accurate, this statement. But of course, the statin, considering heart failure will happen as a consequence of ACS, where the statin is a main to be there. Heart failure can happen in patients with diabetes, where statin is a main medication there. Heart failure can happen with other maybe cardiac condition or IHD, where the statin also could be there. So a statin in heart failure, it is not that strange, but it is not indicated to give patients statin based on a sole diagnosis of heart failure. This one is not an accurate statement, because sometimes no ischemic component and statin will not be that effective. What about the anticoagulation? So anticoagulation, again, there is no routine use of anticoagulant or antiplatelet in patients with heart failure with reduced ejection fraction. except if those patients have AF. And all of us know that atrial fibrillation and heart failure is coincident condition. Means heart failure can cause AF, AF can cause heart failure, and there are so many epidemiological data in this context. Just in brief, in patients with AF, of course, the anticoagulant will be there. So just a summary recommendation, it is not recommended to commence anticoagulant in absence of AF, in absence of a prior stroke, in absence of cardioembolic source of embolism. These are conditions where, if not there, it is not recommended to start anticoagulant. The last, the CCP. The CCP routine use is not recommended in heart failure with reduced ejection fraction, because if non-dihydroiodine, verapamil, diltiazem, it would worsen the heart failure outcomes. If the other one, the dihydroiodine, it has no actually impact on morbidity and mortality, so it is not that perfect. So as we mentioned, diltiazem, verapamil, and perhaps the nifedipine sometimes should be avoided. Consider amlodipine or felodipine if it is really needed to control hypertension, can be added on if the OMT used, the optimal medical therapy used, is not able to achieve, so it can be considered. As we mentioned, it has no morbidity or mortality benefit, but it still can help in controlling the hypertension if it is really or still needed in a given case. In this part, we will be highlighting some points to be considered when we are formulating patient education plan, counseling issues, monitoring issues in patients with heart failure, what we have to consider. First of all, just a reminder, for every medication, there is some advice to be given. So diuretic, for example, the timing, the impact of the diuretic on the fluid balance in a given case, what the issues we have to monitor or looking for. Same for ACE inhibitor, for beta blocker, the ARNI. So this may be a general advice regarding the prominent impact of this medication, what actually the comments in terms of the side effects, the consideration should be given here, what you want the patient to look for, to monitor, what you should consider in educating the patient. All this provided in this table. Here the nitrates, the timing, the headache, the potassium salts, and with other medication, and how this can impact or can affect the patient. Availability of medication, even understanding the condition in counseling it is always before going to discuss the medication. You have to make sure that the patient understands the disease state, and how it is interfering or not interfering with the daily activity, how the coping mechanism overall with the disease, and even before sometimes discussing the individual medication impact. And beside all this, as we mentioned, heart failure is modulated by the electrolyte and water balance. So perhaps the issues related to the sodium intake, the fluid retention, and exercise, also it is important to cover and highlight in the patient education plan. Next, in this section, we will be briefly highlighting the outline of the drug therapy assessment in chronic heart failure. So I believe in the very beginning to understand or to assess drug therapy in patients with heart failure, to understand what are the factors that can contribute to decompensation among patients with stable heart failure. Especially some of these factors can be attributed to a medical causes or medication-induced causes. In general, we have maybe 4 categories of factors that can contribute to compensation: patient factors of non-compliance or dietary issues, cardiac causes, systemic condition, other maybe condition that contribute to heart failure, and some other emotional or urinary tension. It is good to know that among the patient factor, what the medication consumed, the inappropriate medication, and that's why we have maybe the next slide. We have the American Heart Association scientific statement on drugs that may cause or exacerbate heart failure. It has something to do with heart failure outcome. And unfortunately, this a wide or very detailed list. It is maybe important to highlight that in this list we have maybe nonsteroidal, we have corticosteroids, we have some antidiabetics, statins, metformin in certain cases. We have chemotherapeutic agents, anthracyclines, and so on. Pregabalin. We have so many medication in this class, but it is important also to highlight that not all the medication are linked to the same cardiovascular or heart failure outcomes in a given case. Some of them are just linked, some of them are causal relationship, not association, a causal relationship. Some of them have certain consideration or under certain circumstances that this heart failure outcome will happen. So it is good to go in details to highlight this, and I think I will leave this one in the resources under this video. So in this table, I think one of the preferred table for me in terms of the stepwise approach to assess the drug therapy. First of all, screening the patient for eligibility for receiving this medication, whether they need or not. So you ask maybe this patient is a candidate for ACE, beta blocker, MRA, and all these medication. This is the first domain. The next, the need of drug therapy as add-on or as the patient symptoms persist. So if symptomatic and receive this one, what about switching or maybe starting or replacing by iron secupetals valsartan? What about ivabradine, whether or not it considered? What about digoxin? Okay, so what about if the patient have AF, the anticoagulant? How it goes to add and discuss the additional anticoagulant in a given case. What the patient post-MI, the antiplatelet. So all this in the category of optimizing the therapy needed in a given case. Next, ask about the dose optimization, the dose titration, because we have mentioned that some of the heart failure medication, the benefit is just parallel to the dose given. It is dose dependent heart failure outcome. So in this category of patient also we have to plan whether the dose titration is advisable and how it can be done. And of course, the last question or last domain, you want to give all this necessary medication, but at the same time, please be sure that no other medication can harm the heart or have adverse heart failure outcome in a given case, like all these listed medication that I think we have highlighted in the American Heart Association scientific statement that I highlighted in the last slide. Coming to the last section, which is the heart failure with reduced ejection fraction special groups. So the first special group is patient with diabetes. Management of heart failure in patient with or without diabetes is almost the same. But in case the patient has heart failure with diabetes, so you have to pay more attention to the choice of oral antidiabetic, where we have some positive evidence support the SGLT2I in terms of their ability to reduce mortality and hospitalization. We have some data show some risk conferred by agents like saxagliptin and civalidinedione, the baglitazone. We have maybe general acceptance of using sulfonylurea, metformin, and acarbose in patients with heart failure. With metformin, there's some data here and there regarding maybe the risk, but it's generally safe. The second group is the pregnancy, and unlike diabetes, the management of heart failure in pregnancy is much more difficult. And the patient can be receiving the conventional medication, diuretics, digoxin, nitrates, and of course you can see here an OS inhibitor, of course contraindicated in pregnancy. And if patient have left ventricular ejection fraction less than 30%, so in general, it is not advised to be pregnant, and counseling on the contraception should be there. And if pregnant, uh, the termination could be considered. So, and next group is the patient with arrhythmia. Arrhythmia is known to be reversible cause of heart failure, and by somehow the successful treatment, either by the drug therapy or the catheter ablation, will contribute to normalization of the left ventricular function in a given case. Patient undergoing chemotherapy, and the chemotherapy-induced cardiomyopathy, although not common, but it occurs up to 5%. And this actually can be a basis for a careful clinical evaluation and assessment of the cardiovascular risk factor in patient undergoing chemotherapy. The last one is patient CKD. Cardiac and kidney disease is commonly coexisting in clinical settings, contributing to increasing complexity of care and worsening prognosis in certain cases. The management can involve diuretics, RAS blockers, beta blockers, and occasional use of ultrafiltration and hemodialysis.